evening, everyone. I am Dr. Nalini Kaushik, and on behalf of IHW Council, welcome you all to the second edition of Breast Cancer Action Month. In our today's discussion, we would be deliberating on the challenges and opportunities in decentralizing health systems for prioritizing breast health. So before we proceed to today's session, let's take a look at the small AV created by IHW Council, showcasing the significant work and the achievements of last 1 year in the space of breast cancer. Can we have the AV?
Welcome to the second Breast Cancer Action Month, a mega month-long movement to strengthen awareness about breast cancer and encourage action against this fast-growing public health menace.
The bottom line is the lady should be made breast aware.
We are going to get better. The diagnosis is going to be early, and hopefully patients, individuals who are unfortunate to get the cancer will be fortunate because they will get access to better and better treatments.
The individual should be familiar with the normal breast.
It is really important for a clinician to understand the tumor makeup to deliver, to offer the right treatment for the right patient.
We've tried a no-touch screening process, which is more or less like your radio frequency one which you have at the airport. Just have a no-touch screening process.
You should live each day as it comes, and then you aspire to inspire before you expire.
It is possible to cure breast cancer, and they can be as normal as possible in their life.
Our statement of intent says the conquest of cancer by choice, not chance.
It is early to be treated early. That's the bottom line for me.
When they have this cancer, or if they ever have cancer, then we have to see that we give them as a company all the support.
Data, work on big data and how to ensure that data is available for appropriate interpretation.
So if you can tell the oncologist to do PhD, I think your job is going to be done in the next 5 to 10 years.
Basically bring the funding agencies together and to channelize, harmonize and prioritize cancer research in India.
I see a lot of hope in CSR. Corporates can have a cancer fund for their employees. Why not?
Make the education better for consumers, but also the education has to evolve for the medical professionals, the nurses, the health staff and all of that. Put the budget together. How do you find someone to be able to fund all of this?
Investing in screening and prevention is more effective than treating later on.
There must be teamwork or integrated approach of breast cancer management.
Try to catch the cancer early. The treatment is not only curative, it is also very cost effective for most patients.
So as we are coming out of the grip of COVID-19 pandemic and finding our grips again into this world, IHW Council is determined to work in the space of breast cancer more. And the next AV that we have is going to show us the same. So can we have the AV?
Welcome to the second Breast Cancer Action Month, a mega month-long movement to strengthen awareness about breast cancer and encourage action against this fast-growing public health menace.
The bottom line is the lady should be made breast aware.
We are going to get better. The diagnosis is going to be early, and hopefully patients, individuals who are unfortunate to get the cancer will be fortunate because they will get access to better and better treatments.
The individual should be familiar with the normal breast.
It is really important for a clinician to understand the tumor makeup to deliver, to offer the right treatment for the right patient.
We've tried a no-touch screening process, which is more or less like your radio frequency one which you have at the airport. Just have a no-touch screening process.
You should live each day as it comes, and then you aspire to inspire before you expire.
It is possible to cure breast cancer, and they can be as normal as possible in their life.
Our statement of intent says the conquest of cancer by choice, not chance.
It is early to be treated early. That's the bottom line for me.
When they have this cancer, or if they ever have cancer, then we have to see that we give them as a company all the support.
Data, work on big data and how to ensure that data is available for appropriate interpretation.
So if you can tell the oncologist to do PhD, I think your job is going to be done in the next 5 to 10 years.
Basically bring the funding agencies together and to channelize, harmonize and prioritize cancer research in India.
I see a lot of hope in CSR. Corporates can have a cancer fund for their employees. Why not?
Make the education better for consumers, but also the education has to evolve for the medical professionals, the nurses, the health staff, and all of that. Put the budget together. How do you find someone to be able to fund all of this?
Investing in screening and prevention is more effective than treating later on.
There must be teamwork or integrated approach of breast cancer management.
Try to catch the cancer early. The treatment is not only curative, it is also very cost effective for most patients.
Thank you. So breast cancer is the most diagnosed cancer amongst women worldwide, which accounts for 1 in 4 cancer cases globally. In 2020, as we all grappled with the deadly COVID-19 pandemic, there were approximately 2.3 million women who were diagnosed with breast cancer, and approximately 7 lakh of them succumbed to cancer-related death. Now, this points our attention to the high mortality associated to breast cancer. However, it is a cancer that, if diagnosed at the right time, is also treatable and has a good prognosis rate. But due to various factors, the mortality rates are quite high. In India itself, it is said that 1 in 2 women that are diagnosed with breast cancer die within 5 years, showcasing 50% mortality rates. Now, what is really important in such cases is establishment of reliable referral pathways from primary healthcare facilities to district hospitals to dedicated cancer centers. However, in a socio-economically, culturally, and geographically diverse country such as India, where resources are unevenly distributed and where there exists a huge rural-urban divide in the healthcare facilities, and a short decentralized roadmap is a reality that is really, easier said than done. And deliberating on the same, we have a very esteemed and a distinguished panel of speakers who would help us understand where India lies with respect to the question of decentralized breast cancer care and what could be a plausible way forward. So we have with us today Dr. Heera, who is the Additional Health Mission Director, Government of Uttar Pradesh, Dr. Somesh Kumar, who is the Country Director, Jhpiego, Dr. Gaurav Agarwal, Professor, Department of Endocrine and Breast Surgery, Chief Medical Superintendent, SGPGIMS, Lucknow, Dr. Dinesh Pendharkar, who is the Senior Consultant, Medical Oncology and Director, Sarvodaya Cancer Institute, Dr. Priyanjali Datta, she is the CEO at Aaroogya Carnage Breast Cancer Foundation, Mr. Uttar Kumar, who is the Head Market Access and Alliance Management, Novartis Oncology India. Thank you so much, first of all, to all of you for sparing your valuable time, and your participation in this particular panel does, it gives a lot of motivation to all of us in the community, in the advocacy, who are, trying really hard to keep the spirits up for the breast cancer and, get some awareness, in this particular matter. So, Dr. Somesh, I would like to, start with you as we set today's, context for today's discussion. So, there has been a very strong focus on expanding universal health coverage in India. And even with, like now there's a huge growing burden of cancer, especially breast cancer, where the need for UHC is being felt more. In this case, how do we go about rethinking cancer care across the country? Over to you.
Thank you. Thank you, Nalini. So, yeah, it's the universal health coverage is a pretty ambitious agenda, right? But I think it also offers a great opportunity for us to use that lever, the tailwinds behind the push for universal health coverage, to ensure equitable access to cancer care, including diagnostics and treatment. So I think the roadmap for this is pretty, multi-stake in terms of how do you make sure that you are taking a total market approach to ensuring that each segment of the market is leveraged, is tapped to ensure the services of different segments of the population are being provided to. So what does that actually mean? So there is that public sector which is the predominant deliverer of the services for the larger society, where especially the underserved ones. But there is the mistrust between the public sector and the private sector has meant that there is a absence of deep engagement between the public and private sector for making sure that the private sector presence as well as their enterprise, their innovation capabilities are leveraged, are not leveraged actually to ensure universal accessibility to services in a manner where the client does not have to pay the brunt of the financial cost. So that is the kind of the approach we have to take. We have to take a total market approach, look at the presence and the presence and the enterprise of the private sector as well as the public sector in a whole, as a whole, and bring the various capacities and capabilities of these systems together to then provide these services. And finally, to make that whole system work, you have to make sure that first the trust barrier is reduced, the financial intermediary capabilities are taken care of, and also making sure that that the package of services are included in the UHC package of services, which is then funded by both the national government and the state governments, and a differential component for extraordinary expenses which cancer sometimes can cause, cancer care can sometimes cause, is accounted for that. And there are many examples, like in Philippines, like in South America, Brazil, and others, where this has been done in, and so countries like India, in a developing setup, in a resource constraint, can learn from those experiences.
Absolutely. Thank you, Dr. Somesh. That was a very broad and a holistic, perspective on the health systems and how we can move forward, on that. Dr. Priyanjali, I would like to bring in that we heard a health systems perspective there, and I'll take the liberty of saying that, you've been a very strong proponent of accessible and affordable cancer care in India, right? And by virtue of the kind of work you've done, what does decentralization of breast cancer care really mean for you? And what are the specific interventions? Like Mr. Somesh said that, there are certain global experiences that we can learn from. But when we think of, a resource stratified setting like India, what do you think? What could be the specific interventions that could be made? Over to you.
Thanks, Nalini. And Somesh made really good points, so I'll just build on that. What Aaroogya faced 4 years back when we started was on-ground interventions for early detection of in states like Meghalaya or Uttar Pradesh, Bihar, and Uttarakhand, West Bengal, wherever we worked. we saw that, the amount of population to be covered in India in a scalable manner is definitely a big constraint in terms of manpower, resources, and accessibility. So how do we set up a system of uniform screening on a very large scale at a regular interval, right? In a very lean fashion. And India became from an on-ground organization to a technology-led organization where we provide our customized mobile application, which is powered by artificial intelligence-led algorithms for doing the risk assessment of diseases like breast cancer in women, right? That is one of the way where interventions can be made for a complex geography like the Indian subcontinent. The country has seen the importance of digital infrastructure for health during pandemic. And in February 2020, WHO released a study saying 1 in 10 Indians will have cancer in their lifetime by 2030. And the top cancer is going to be breast cancer. So naturally, physical infrastructure for so many primary health centers to be doing screenings on a regular basis for women everywhere is not possible for us to do very early. So what do? We take the help of technology, and that's the only way where we can match the solution to a scalable manner as the problem is. So yeah, I think that's my take on it.
Absolutely. Thank you, Dr. Priyanjali, because you talked about universal screening, and as much as we keep talking about universal screening when it comes to cancer, the question is also to make it uniform. And how do we make an intervention using technology is a big, point to discuss. And I think in the due course of today's discussion, I think that's one of the critical aspects that we would be picking up on. So before that, I think I would like to move on to Mr. Uttar. Again, we're talking about decentralization here, and you're representing a pharmaceutical company where working from the supply side, it's really you're the one who's your company and such other companies which make that particular contribution on that side. But then from your perspective, how important is decentralization of cancer care, especially for breast cancer in the Indian context? Why can't we just keep it centralized, in fact?
Thanks a lot, Dr. Nalini, for the question. That's pretty critical question for the forum that we have today. Right. First and foremost, the first thing I would like to state that there have been significant advances in treatment of breast cancer. Right. So over a period of time, we have a stage where if diagnosed early and provided with the latest treatments, patients can live with breast cancer period. Right. But then the key things over here are the early diagnosis and the right treatments, which is going to be critical in management. Right? Breast cancer does not discriminate. It affects women across the country, across regions, across income levels, across whether it's a metro, little city, town, or village. And hence, it's very essential that we build equity in cancer care, so that a woman patient, whether she is in a metro city or in a village, is able to access appropriate care for the treatment of breast cancer. And that's the critical role that's where decentralization comes into picture, right? It cannot go to the hospital. Then how can we get the hospital, the health system to go to the patient? So that we are able to ensure that there's equitable cancer care. So I'll also be happy to say that we have been supporting Jhpiego in some of the work they're doing on the proof of concept, the pilot for ensuring continuum of care for breast cancer from screening to treatment to follow-up in the state of Odisha. We have seen some good initial results coming in from that, and we'd like to see how this can be built and scaled up so that we are actually having a appropriate continuum of care and being able to decentralize cancer care for breast cancer specifically across the country.
Right. Absolutely. And I think you mentioned Jhpiego's role in decentralization. I think Jhpiego is doing a lot of work. One is at the implementation. Another is also, I think, at the policy level of giving, certain technical support to the state government. And I think those are the case studies in the due course like to hear, because they are in a way case in point for us. So on the point of discussion that we want to have, moving on to the two doctors who we have on the panel, because and the reason of bringing them now is that I first wanted to make the other stakeholders speak, and then put a perspective to all of that from the two eminent doctors that we have here, that as medical experts and you're the caregivers, you have an increased responsibility in a very traditional sense, which is bestowed upon you by the patients. And both of you have a very strong presence, at the state levels in India. So as a solution provider, what kind of challenges you face when it comes to delivering effective care to the patients, and what can be done in that particular matter? So we will start with Dr. Dinesh from you. Dr. Dinesh, you're on mute. Could you please unmute yourself?
Hello, am I audible?
Yes.
Okay,
you're
so first and foremost, I would like to tell you very frankly that there is no issue of centralization and decentralization as far as breast cancer care services are concerned. Breast cancer services of care are fairly well decentralized. There is no issue at all. I cover 200 districts of the country, and patients are being seen everywhere and being assisted everywhere. There is a problem. The problem lies not in the care. The problem lies not in the services being decentralized. The problem lies is some basic medical procedures unfortunately, majority of the services which patient accesses. So if in a district is patient, majority of the patients are accessing a hospital A, unfortunately, the diagnostic district services are not required today. In any case, pathology services are centralized in the country. The specimen goes somewhere else for reporting. So that is again not an issue. But doing a procedure is not happening. So my humble request to all NGOs and organizations, please let us make a roadmap of 2 to 3 years how we want to actually tackle the disease. Let us forget early detection of breast cancer. Let us forget all those things. They are fine. They will really help us. But we have to set up a chain of logistics. If a patient is suspected to have a lump in the breast, he goes to a hospital A, which is there in a district. The hospital should be able to do a basic procedure called biopsy. Unfortunately, this is not happening. So we have to work on how do we do that. It sounds very, very probably not mature, but this is reality of the country. I work with districts. I know what problem I'm facing. A biopsy done is a problem. Then getting the biopsy reported is a problem. But fortunately, majority of the governments have actually authorized the government hospitals to send biopsies wherever they want, wherever possible. So there are regulations to this level. So government at its level, the states at its level have really done a lot of things from their side as far as the administrative issue is concerned. But still it is not happening. So besides the legislation coming from the top, the middle level and the lower level is not cooperating with the legislations. How do we do that? I don't know. Probably an NGO has to play a role here. So what we have to do is we have to teach to do the biopsies at a district level, and then we have to streamline the logistics of reporting. As far as finances are concerned, it is not an issue. The money is available. The pathology reports, governments are really offering to do free of cost. So that if these two things are done, the third thing in the care becomes surgery. Believe it, physician is one of the simple surgeries which majority of general surgeons can be taught to do in a very short period of time. So again, this is not a big issue for a country like India to say that we cannot treat breast cancer. Then comes issue of chemotherapy. Chemotherapy is must in breast cancer. Every patient has to take chemotherapy. And fortunately, I can tell you, we have been able to set up district cancer chemotherapy centers, and which are offering chemotherapy for as long as now. Some centers are 7 years old and they are beyond 150. If some centers are not doing well, then again, it's an administrative issue, not issue with the doctor or not issue with the government that the drug is not available. All basic drugs required for adjuvant chemotherapy of breast cancer are available in the districts. They are being provided by the government. So again, delivery of basic drugs required in adjuvant cancer care is there. So they no issues. There are these technical issues where somebody has to pitch in, somebody has to really sit, understand the problem, and push the things to happen. They can happen very easily, and breast cancer can be tackled in the periphery without any issue, without putting in really extra financial or other resources. Once this happens, then I want people to do mammographies, bring early patients, bring them for biopsies and bring them for treatment. But first, let us set chain of this logistics chain of doing biopsy, then doing surgery, and then offering chemotherapy. All technology is available, but these things are not happening. Somebody has to really pitch in and see how we can do that. Thank you very much.
Thank you so much, Dr. Dinesh. And amongst the many, many useful things that you talked about, like firstly, that, there's maybe no issue with decentralization. Rather, the problem lies, with the availability and accessibility of certain services. And of course, you recognize the role of many other actors, such as NGOs, and I think it's the Constitution of India, which so many decades ago actually recognized the decentralization component under the directive principle itself, and health is actually one of the aspects recognized there itself. So Dr. Gaurav, I think we have heard all our panelists today. I'm bringing you at this junction because we recognize the kind of work you've done and the kind of experience you hold again at the state level to, in the space of breast cancer. What do you think, from the perspective of decentralization that, yes, we know that in a certain form, in certain capacity, it does exist. But what are the challenges, and what can be done in that regard? So you're on mute. Could you please unmute?
Thank you. Thank you very much for having me in this panel. And well, I feel breast cancer care is a continuum. We'll be fooling ourselves if we do not pay attention to any of the various components, right from awareness, early diagnosis to imaging and surgery and adjuvant treatment and supportive palliative care and survivorship issues. All these are interlinked. If we miss one of these key links, we would fail in our efforts to provide a holistic care to our patients and improve the outcomes. Now, how do we go about doing it? Centralized care is unfortunately the current rule of the game. And as you rightly said, there are efforts to decentralize the care, at least to some extent, but it's not. And there are some very good examples, excellent examples of success, but unfortunately we are still way off the mark as far as decentralized care or accessible and quality care is concerned. Sitting in an island of excellence, at times I feel very elated that we have a team of excellent people here who can provide things or care at par with the best in the world, and perhaps this is what we tend to believe. But as soon as I take my blinkers off and start looking at what's happening across the state, across the country, all that elation, all that sense of pride wanes off. So there's a lot to cover before we can say that we have arrived, we have done what is required of us. So coming to the moot question that you asked me, what do I see in terms of where do we need to go? How do we decentralize? We have to build in a system, and then we have to take all possible help from technology, from uh, public sector and private sector leaders, and all possible help from any quarters to create all this infrastructure and environment to provide decentralized and quality care. The and it was made by, I think, Priyanjali, that the mere size of our population, of our continent, not just a country, as diverse as the whole globe, as diverse as both in terms of our population and the infrastructure and the levels of understanding and comprehension of various health issues, and as well as diversity in terms of access to care. We have, on one hand, a set of, unfortunately, very small number of people who can take any damn thing under the sun, and they can afford that. But unfortunately, we equally have a huge population who can hardly afford 2 square meals for the day. And how do we expect them to be even undergo a surgical procedure or a diagnostic procedure? So we have to deal with this diversity. We have to come up to the expectations of all the people in this huge spectrum. I merely because we are a developing country, we cannot shut our eyes and say, oh, we will not bother about targeted treatment. We have to equally be bothered about that, while also focusing on providing cost effective solution to the masses. And so it's mind boggling. It's something which kind of weighs us all down. We weighs it under the whole weight of this enormity. So what we need to do is evolve uh, strategies of which are cost effective, which are sustainable, which are help. I mean, um, artificial intelligence and technology is all welcome. Unfortunately, we still have to go to the ground, so to the ground level, to the remotest of possible places, to motivate women to come for evaluation and for treatment. They may be aware of a problem in their breast. Many of them are symptomatic, but merely or because they're afraid of either they're ignorant or they're afraid of the cost and the trouble of visiting a hospital. They do not come up for the treatment. So we have to create this entire chain of consistent and convenient infrastructure and systems or in facilities where women would not be afraid of coming to. So unfortunately, these are all, I mean, this is such a mammoth task that cannot be discussed and cannot be achieved in a small space of time. So what we can perhaps do is make a beginning in our own ways, as I'm sure so many have done. So many people have done extraordinarily great work, Pendharkar included. I'm really appreciative of the kind of work he has been able to do to reach out to such a mammoth proportion of population, yet that remains a minuscule proportion of the entire country's population. I guess the challenge I see for myself is not as a surgeon, not as an oncologist, but to widen my horizons, to widen my perspective, to include some sort of public health and advocacy kind of things as well. Because sitting, as I said, in my ivory tower, I'm not achieving much. I may be treating my patients, the limited number of those which I'm treating, and my colleagues too, very well. But that achieves a very small proportion of what we are expected to do. Awareness is the key. Awareness not just about the disease is enormous, is the largest or the largest killer in terms of cancer-related deaths. Also of the fact that it is a curable disease, and take care of or dispel all the myths and misconceptions. Not just that it is painful to undergo treatment and then chemotherapy hurts and surgery hurts, but there's a light at the end of this tunnel. And I'm totally at loss. I'm not the right person to answer all these questions, but I am at least aware of the questions that we all need to answer.
Absolutely, Dr. Gaurav, and I think thank you for pointing our attention to all the right questions. And I think what's really critical before we move towards an answer in form of any policy or any other intervention is to have the right questions. And I think you've actually pointed us towards all of those important questions. And you also started by saying that how all the other aspects are interlinked, whether it is screening, whether it is diagnosis, treatment, even awareness, advocacy, everything. When it comes to cancer and breast cancer, everything is interlinked. And while I wanted to sort of move on to the other set of questions regarding data, but I think I see sort of a coherence between what you, Dr. Somesh and Dr. Priyanjali said today. And I think in a way, I think our entire panel, I think we can agree or maybe agree to disagree that all of us agreed with the fact that decentralization in some form or the other, of course, we know that it does exist. But it is so sporadic, that there is no convergence at a pan-India level. And now if I sort of rethink what three of you have specifically talked about is that, because it is about health systems and lack of this sort of convergence. And if I can just circle back to Dr. Somesh, to you first, that, what do we need then? Do we need a policy which was led by the central government, or while we do have a program at the center level already existing, but now today when we're talking specifically about breast cancer and universal screening is already taking place, and we have seen certain developments with all the challenges that we have discussed by thus far discussion. What do you think? Why do not we have to bring that coherence there?
But it comes down to who owns it.
Yeah.
And that's where I think the for all we talk about public and private sector, health is a public good, and the government is mandated to, in a welfare country like India, supposed to be ensured by the government. So let's take a successful example of another disease, how a disease has been addressed in a multi manner at a very mammoth level. And there are lot of dissimilarities, but there are similarities to be learned from. So let's take an eradication exercise like a polio, right? So it is not, it sounds very simple polio vaccination for eradication. It was not simple, because we are talking about not control, we are talking about eradication. So it needed multi-dimensional effort. It needed lot of engagement of the pediatricians, neurologists to detect, create those surveillance systems. It needed laboratory systems to test a lot of stools for polio cases, immense Herculean vaccination efforts. It needed vaccines to be available to the last mile. It needed the logistics. It needed the government, leadership at the district level, at the district task force level, to with the district magistrate leading it. And finally, it needed social and behavior change, because there was a lot of vaccine hesitancy. Now, it's just an example. There are a lot of dissimilarities, but why it succeeded in India? Because all the stakeholders came together under the leadership of government at all levels of the health system. right from the national level, where the health ministry made it and the government of India made it as a global priority, it's a national priority, to the district level, where the district magistrate used to hold a once in a month meeting to take stock of the polio eradication. That's how the accountability came. So for me, I think be the coordinator of this effort, be the steward of this effort. I think the policies are there. What is lacking is the 2 or 3 things. First, the resources behind this policy. Sufficient financial resources at the national level and at the state level to make sure, and also at the district level, for example, to make sure the different domains of cancer care, as Dr. Gaurav pointed out, it's a multimodality, it's many diseases in one disease. So you need resources to be able to, you can't create an infrastructure overnight district, right? You need to, but you can't wait for, also setting up the whole lab system and in the meanwhile doing nothing, right? So how can you have resources to buy services from the providers and systems which are available already, or have solutions like tech solutions, etc., for making sure that infrastructural barriers are mitigated? You need resources there. So, but my sense is those resources need a lot of advocacy to be unlocked. And for that, breast health, breast cancer will need to be prioritized. Breast cancer along, a maternal child health or any other thing. It has to find its light under the sun with the government. So advocacy is very important. What is also very important is a platform to build all these stakeholders together. And that's one solution hypothesis that Jhpiego is thinking of working in one state. Maybe it is Uttar Pradesh. We don't know yet. We'll think through that. But we are thinking of creating a platform where we bring in the various stakeholders together, led by the government, but stakeholders together, which can then facilitate a holistic conversation, but also catalyze action. So, if a state needs, X chemo drugs, and if a supply is ready to provide those drugs at all levels at a subsidized cost, which they know, currently there is a lack of platforms to make sure those connections are there, the coordination is there. So that platform to create those linkages, those facilitation of those convergences is required. So that's the second important effort that is needed. And finally, we have to demonstrate the operational mechanisms of how to implement that entire continuity at a reasonable scale, because India is a country of great guidelines and policies, where we kind of falter, and very understandable why we do that. Huge country, different context, we falter in the operationalization of it. So how do you demonstrate at a reasonable scale in different contexts of how you operationalize that care pathways? How do you do the diagnostics to a district hospital? Complex.
Recording in progress.
Necessarily complicated. I said complex because complex means that you need there are multiple dimensions to it. It's a mammoth and a complex ask, but you need these kind of levers to be leveraged for making that making progress in this case in a sustainable and scalable manner.
Absolutely. And I think what you said, I think in healthcare, we have very long, we have been talking about, bottoms to top approach, because top to bottom has already happened. But I think from what you said and what we are seeing, specifically in the context of breast cancer, if I can put it this way, that, we need to sort of marry somewhere, the top to bottom approach and the bottoms to top approach. I think both the hands have to just come in together. And who is at the center of it, who sort of take the onus, I think sort of clear that, we need the government to sort of do something about it. But then, yes, in a certain way, in some capacity, that marrying of the two has to happen. Dr. Dinesh, we heard from Dr. Priyanjali towards the beginning. She pointed at the data, that WHO data which came in the beginning of 2020, that how India is very very significant, that there's a very significant rise in the number of cases, and how vulnerable we are in the next decade, the population of India to breast cancer. I'll put the same question to you, that we know that sporadically so much is happening, and you also, while you were talking, you said that yes, there's so many models that are happening. Again, I think I would take the liberty of saying that maybe many of them are sporadically distributed across the country. We need to there's a need to bring sort of convergence in them. So how do we bring that? Do you also think that it has to be the central government, or maybe the NHM, and so we can take certain ownership under NHMs? What would you like to say on that? Sir, you're on mute. You'll have to unmute yourself, please.
Okay. So see, let me tell you very frankly. Let us dissect cancer one by one. So let us take only breast cancer.
Yeah.
So what is required in breast cancer is detection.
Yeah.
So in detection, we got enough NGOs who are working in the periphery, who can do public education and educate ladies on what is breast cancer. So, and we have enough NGOs working on it, and let them continue to work on it. Then one should understand that if we are really talking of a mass population, please speak only of, somebody has already said it here, talking of a mass health care or mass health issue, then to bank only and only on government sector. Okay. So the most important, then the next topic comes is diagnosis. So what is diagnosis in breast cancer? I'm talking specifically breast cancer. Breast cancer diagnosis means taking a tissue for
I think we have missed Dr. Dinesh.
Is not happening. Okay. Yes. Hello.
Yes,
So
yes,
surgeon
sir.
has to be taught to take the biopsy. This is a number 2 issue. Then the reporting of the biopsy. So remember one thing, please do not invest money in creating center of excellence of pathology in every district. The time is gone. Every state should be asked to create a central pathological laboratory in a central place, and we have to just take care to set a courier service, which we have very well done in COVID. All RT-PCR samples were transferred from villages, from districts to one RT-PCR lab in the state, and they were reported. Same thing should happen in pathology. Setting up a pathology lab is not at all costly. The finance is already available. There are already a lot of pathologists working in the government sector. They can be brought under one umbrella. So you should start a central pathology and just create a logistic system of sending this biopsy samples from the district level to this lab for reporting. And your issue of diagnostics will be solved. Yeah. Not a tough job, does not require finances. But somebody has to take a decision that this is how I want to augment my pathology. Once I've augmented pathology, then comes the care or the surgery. Again, the number of breast cancer, rightly said, is very high. So they cannot be operated centralized. They have to be operated decentralized. That is again to create a workforce. I said, as far as surgical skill is concerned, this is one of the simple surgeries. Any general surgeon can do it with just a minimum training of maybe 7 days, 5 days. It's not a big surgery. Majority of them actually do it. So my district in Dantewada, which is a Bastar area, very deprived area, we are doing core true cut biopsies in a government district hospital, and we are doing modified radical mastectomies in a government district hospital. This is happening.
Right.
So it is doable. So and then I augment the surgeon, and then I naturally provide all districts with possible drugs for chemotherapy. So taking care of a breast cancer patient is not difficult. And I just request all the agencies to come together and take one part of it. So one agency like Jhpiego may decide I will train surgeons in breast biopsy. A very simple task. Actually, they can finish a state within 2 weeks because it's just 2 days training. And somebody has to do it at a national level.
I think we have some weak connection from Dr. Dinesh's side, but I think what he's really pointed out is that, by giving this example of pathology and biopsy.
Thank you very much. Go ahead.
Yeah. So thank you, Dr. Dinesh. There was a slight network problem from your side, but I think you rightly, pointed at some really important aspects that, by giving this example of pathology labs and biopsy, that instead of replicating what already exists and wasted of resources, it is all about, making some smart choices and solutions now, and how different stakeholders actually can come together and take the onus and the ownership of certain things, and us also not residing all our hopes on the central government and, leveraging the government wherever it's possible, but also take some ownership from our side. And as we, we grapple more with the question of who takes the ownership, I think the role of technology really comes into play by that. While technology cannot take the ownership, but the role of the interventions made by technology are very helpful when it comes to, decentralization. And while I would be throwing an open question to all our panelists, but I would like to start with Mr. Uttar that, what role do you see when it comes to mobile connectivity, data, digital, what role it can play in the evolution and implementation of breast cancer related policies and health programs, in India at the state levels?
Sure. Thanks, Dr. Nalini. So I couldn't actually agree more with what my panelists before me have talked about, right? Which is about the need for convergence, right? And the mobile connectivity.
So anybody, energy efficient, but unfortunately, the work has to be carried out at a district level. Nothing is going to help you. In a district, only thing which is going to help you is yourselves approaching that surgeon and then asking him to do the things. And if he doesn't do the things, then involving the state and making an order, and so they work.
Absolutely, Dr. Dinesh. And I think if I can just recapitulate, I think again, he's very, in a very simplistic manner, he just told that how the bottoms up approach that we talk about, that involving the district authorities, and then if that doesn't work, involving the state, and then go up would work, specifically for breast cancer. Dr. Again, back to you with the point that you were making.
Yeah. So the couple of things that's happening as we speak, right? One is that mobile connectivity has reached out to the remote corners of the country, right? Data plans are so cheap, right? India has become like the video streaming capital of the world. Right? So now, how do we leverage this for something beyond just entertainment and to actually bring impact and contributions lives? One of the key things about convergence is about being able to have a unique patient track across the various components of the health system. Right? So the National Digital Health Mission that's been launched with an integrated healthcare stack can play a significant role in being able to track a patient and provide a uniform experience for the patient, as well as enable the health system to integrate the various components into a single patient care pathway. Right? And that is going to be a critical component for doing a decentralization. So decentralization doesn't mean that each one of the things is going to operate on its own, but rather to operate and provide a single experience to patient across the entire patient care pathway. The second key impact I would say has been the impact that the COVID pandemic has had on us. Digital adoption has increased, even in health space where the number of virtual consultations have gone up significantly, especially during the lockdown. So while there's been a significant negative impact, there's also been a lot of positive impact which has come up from this in terms of increased focus on health, increased focus on digital health, and bringing in the technologies which can help in having better remote care and which can also support decentralization of breast cancer care over a period of time.
Right, absolutely. And I think I'll move to Dr. Priyanjali here that, while I would pose the same question at you, but from the perspective that, if we go beyond the traditional approaches, and I think your organization and of course Jhpiego also, you've been involved in, more like, going beyond the traditional approaches where Jhpiego has involved the nurses and, the ASHA workers, allied staff when it comes to breast cancer, and of course expanding the scope when it giving the due recognition to that staff as well, that because it's just not the doctors at the end of the day, it's the other healthcare force also which has a critical role to play in that. And your organization also is somewhere on the similar lines and conducting those workshops when it comes to breaking taboos and all. So where do you see, how do we use technology there, but also not concentrate technology for, the newer inventions only for the doctors, how do we capacitate many other people who are, critical component actors who are critical component of the, health ecosystem? How do we also capacitate them when it comes to technology and bring wider solutions which are more sustainable, in fact? Over to you.
Thanks, Nalini. And some really great points came up from all the panelists. And about your question specifically, I've been very closely following Jhpiego's work, and what Aaroogya is currently doing is, really something very simple. We focus on the bottom of the pyramid, the intersection where your population's pyramid, healthcare pyramid, and technology and the new innovations lie. We are at the intersection of that. The problem statement here is, how do we solve the entire complexity of having a linear patient journey, as Uttar rightly said. And the role we are playing is, we are giving the customized technology in the hands of ASHA workers, who are the first line of interaction between the population, the community, and the healthcare pyramid. They are definitely semi-skilled, but they have had the courage and right training over the period of time for maternal and child care and immunization. So why not a complex disease like, breast cancer screening? And if technology is not a solution, right? It's an enabler. And the moment you do very simple things, as simple as translation of the entire patient, journey and care and screening method in their local languages, these ASHA workers can play a significant role in doing early detection of diseases like breast cancer. Number one, because the social taboo around it is so strong, and I will share it, some videos with everyone, some documentary films that we have made. Different states, different villages, different districts, and even in a state like Uttar Pradesh, which is so huge and so complex, in a radius of 1 kilometer in the western UP, when we were doing our first few POCs, we saw very huge differences in the entire approach of how community responds to healthcare, especially primary healthcare, in a radius of 1 kilometer. That was a very enlightening journey for the whole team, because India is evolving very fast. We all are at a space where we are doing our best in every field, and that is why this may be the right time to bring all the elements together and plug it maybe to a centralized system like the National Digital Health Mission, as Uttar said. So we all have to think about very simple solutions at each level of the health pyramid, plug very easy solutions, and just, scale it up. So yeah, that's my take.
Dr. Nalini, you're on mute.
Thank you for that. So if we, thank you, Dr. Priyanjali. So if we look at the health pyramid of India, there are a lot of solutions and intervention which exist at different levels. I think it's time that we use or leverage certain enablers. Of course, technology is a huge enabler on that particular front, but there are many, many other enablers. How we leverage those enablers and bring sort of, convergence of all these interventions. And I think if we end up, sort of think through that, I think my question, who takes the ownership, would actually dilute down to a huge extent, where we all start taking ownership of, the action and the capacities that we have at that level. Dr. Gaurav, I'll just come to you with the same question. While we have heard, the challenges, but then technology again is an enabler. Where do you see the role of technology here, and how do we, go beyond the traditional approach of technology, and how do we broaden the scope of technology so that we build more sustainable solutions?
Yes, technology is indeed a great enabler, and we would be fool if we were not to take fullest use or make fullest use of the available technological tools at our disposal. And I would like to point out a few examples and to put across my views in each of the various facets of breast cancer care, starting from awareness and early detection to local regional therapies and surgery, and then systemic treatment and survivorship. I feel today in this connected world that we live, at least half the Indians are truly benefiting from the connected world. The social media is playing a huge role in terms of the service providers, be it at the primary level or in referral centers and tertiary centers. Social media and internet technology is helping rapid dissemination of knowledge and rapid training of people of all nature. And then something which is happening already but needs to be strengthened. Early detection again, and then awareness of women, and encouraging them to detect their cancers early, if at all they have to have one. Again, a lot of it can be achieved by use of mass media. It's being done, but needs to be improved further. I would have liked to see a much wider, much more aggressive mainstream media campaigns, both in electronic as well as print media during this month. But for various reasons, we do not see as much as all of us would like to. What prevents both governmental and non-governmental organizations to put in a 30 seconds film at the beginning of every prime time debate in various channels. But of course, that speaks, the reason primarily is the low priority we accord to health as a whole, and cancers and breast cancers in specific. Early detection awareness is important. So is diagnosis. Dr. Pendharkar has been very vocal about how even a simple biopsy seems to be a hurdle. It's not just the lack of training, appropriate training for the surgeons or diagnosticians, the infrastructure. The core biopsies that we take for granted in majority of good centers, the biopsy gun, the spring-loaded biopsy gun that we use every day, costs say 1,800 per biopsy gun in my hospital, which is a subsidized cost, and perhaps 2,400 rupees per biopsy gun. There is need for a low cost, perhaps technology biopsy gun, the kind that one of my student has devised in Jabalpur. And of course, it requires to be used widely. And the cost is only 50 rupees using an entrapment of just ordinary syringes, 50 ml syringe and a 5 ml syringe. But those kind of biopsies are needed. to be used, and not just by a few, but across in various places. And of course, it would also require training. These are, in a certain way, the need for this training is a commentary, or rather a sad commentary, the standard of medical education across the country. These are such basic diagnostic tricks or procedures which must be told, which must be taught to every medical graduate across the country in all colleges. But sadly, it doesn't happen. So there's a need for this to be done at the tertiary level, at the level of the practice being done. Of course, there's always a scope for improving and always a scope for continuing training and education. But here, the basic problem is standards in medical education and medical training and surgical training. Again, technology can be of can certainly not just people remotely or in a smaller groups, but also mentor them on the job. For a well-trained surgeon or a oncologist to be present in each and every small hospital at all times, but there can be telemedicine help or telementoring help available to these people who have just started doing these procedures. And then, as Dr. Pendharkar said, it's not difficult to master these techniques. And this can be mastered in a span of, say, 20 odd procedures. In terms of surgical training and training in basic oncology care, of course, we are using technological tools at all level, from the basic education down to mentoring surgeons working in different areas. Of course, no doubt, modified radical mastectomy is a much simpler procedure compared to many others, say a Whipple's operation or many other operations. But at the same time, not done well is a disservice to the patient.
Right.
So we have to ensure that appropriate training of surgeons who are doing these procedures and continuous training and mentoring is required. And then, mind you, radical mastectomy or modified radical mastectomy is not the only procedure. In fact, that's not the desirable procedure in majority. Today, in this day and age, we would like breast conservation to be the norm and then not mastectomy. But yes, as a most frugal, most basic procedure, it is acceptable. But we would like more and more surgeons to be trained in carrying out breast conservation surgery. And same is true with various other facets of multidisciplinary care. So technology is indeed the answer, both in terms of training as well as mentoring of people or the personnel who are going to deliver the care, but also monitoring the care. Now, it's equally important that we monitor if we have decent.
Recording in progress.
Sum up a couple of questions together and request an answer from you. Is that, first of all, of course, I would like to hear from you the use of technology, because anyways, a lot of work that Jhpiego does is interventions are based using technology, but
Recording in progress.
Everybody together and building sustainable solutions in that regard. So if you could just, shed some light on the work that Jhpiego is doing Also, since we could not have Dr. Heera from the state as a state representative today, I think, correct me if I'm wrong, that Jhpiego has actually contributed in building technical assistance for some building some evidence-based models, at least for certain states. So if you could just bring in certain state perspective from your experience on that. So two important lengthy questions, question which might have a lengthy answer, but if you could just summarize a response for that on that for us. Over to you.
And so,
can I just intervene for a minute, just 1 second, if not possible?
Yes, sir. Please go ahead.
Yeah. See, I just wanted to say, I'm really sorry I'm getting disconnected all the time. Actually, I'm in Kenya doing cancer camps in multiple districts of Kenya. And I'm on the highway, that's why I'm getting cut actually. And humble request to all is, please organize a one in-house meeting and not Zoom meeting. And these issues can be really resolved in just one day. And we can come up with a national policy, how we want to do year 1, year 2, year 3, and reach somewhere. Thank you very much. Sorry to intervene.
Thank you so much, Dr. Dinesh. I think it's fine because we understand the kind of technology which is binding us. It can be erratic at times, but I really appreciate the commitment that you're sitting, in one corner of the world and supporting the panel discussion, today. I think we have lost him, but I think it's incredible to see his participation and passion for the work. And secondly, what he said that, let's go offline, and have a constructive discussion, maybe in the due course of time, because the way even IHW is motivated to bring in a lot of solutions in the space of cancer, maybe in the due course of time, we would see all of that happening as well. So Dr. Somesh, over to you. For the time being.
So Nalini, just wanted to sort of clarify the first question. Did you want me to focus on the technology bit of Jhpiego's work, or generally our role, our work in this space, and then of course the state TA is different.
Yeah. So given the paucity of time, I think if you could just focus on the technology part and how are we, taking the nurses and the entire, the ecosystem together in building those solutions. If otherwise I would have dissected the question further to have an elaborate discussion on that. But given we have some paucity of time, so over to you on, in summarizing that for us.
Sure, no, that's fair enough. So I think Jhpiego, we HRH and training, it's one of our core competency domains. Actually, I don't know, 46 years now, or 48 years, something like that ago, when Jhpiego was formed. It started as the program for education. It was Johns Hopkins program for international education for Ghanaian ops. And now, of course, that's an acronym. We are doing many things at the health systems, most things at health systems level. So we take capacity building, very seriously. And so we have brought all of our experience in, in working with the different cadres of the health system to make sure that they are enabled, empowered, and also equipped. All the 3 E's: enabled, empowered, and equipped to take care of the patients and the clients from their job description standpoint. So in terms of breast cancer care, so what we have done and still trying to do, it's a work in progress, I would say, is using tech-enabled capacity building approaches for making sure our frontline workers, be it ASHAs or ANMs, and even the staff nurses and now community health officers at the health and wellness centers, they have learning resources for getting refresher training on both the domains of awareness generation, the 6 key signs that are you should be bringing to the attention of healthcare providers, and related issues on know your breast, etc. So breast health awareness, also on clinical breast examination, because sometimes a provider, even if you train them in physically, they might forget. So we are using tech solutions to for capacity building. We are also trying to create a social learning network, and this is just something that we are starting now, because and it's one of the dreams that we have is cancer care needs, and it needs multiple sets of providers, multiple cadres to come together and work in a team environment. Even if they are not working concurrently, eventually they are all contributing. So how can you create a social learning network of these providers, where this network can be a perpetual affair, where if somebody wants to ask a question, he or she doesn't need to go to some individual person. It can be a social learning network so that is an experiment we are trying to create. It has worked in a lot in other domains. We think there is a role there, and we will be partnering with one of the tech giants to create that social learning solution, social learning network. So the second area that we are trying to look at tech is decentralized diagnostics. So again, it's an exploration stage thing at this point. So we are in talks with NCI, National Cancer Institute in the US, who's funding a lot of cutting edge technology experts who want to contribute to social good, not only for profit motive, to bring solutions for breast care, early diagnosis and detection. So there's some handheld ultrasound device which can be used by a nurse to detect and diagnose a cancer. So those kind of technologies, we are trying to explore and track, and we do feel again the other one we are working with is with Cepheid. They are working with for using their the automated platforms which are now available everywhere thanks to COVID, of how they can use a panel of tests to do the biomarker identification. So you don't have to send big samples to samples for big and expensive tests. You can do it right there in your district hospital, where you have the rapid the PCR machines that we talk about. So we are trying to follow these newer cutting edge technologies that are coming up for diagnostics. And finally, we are also working again currently in the exploratory stage to talk to some AI companies for clinical decision support tools, especially for the physicians and at the front end of for chemotherapy at the district hospitals, etc. So if you remember, this group. Forgetting the IBM Watson, they came up with that group that those algorithms to help in the training in the drug prescriptions for decentralizing care in African settings. And so we are also trying to collaborate with some of these groups with some very basic solutions. We don't want to decentralize the whole thing.
Yeah.
But for example, can such a CDS, clinical decision support tool, help in maintenance therapy at least? So those kind of very basic clinical decision support tools are probably something that we can all explore to see how you can mitigate some of the HR barriers that we have. There is somebody, and finally, in the tech space, the ASCO, the American Society for Cancer, rather ASCP, American Society for Cancer Pathologists, or something like, there's a gentleman called Dan Wilmer who's doing some very great work on telepathology and at a very big scale. So we are testing the feasibility of those solutions on, is that something doable and replicable at scale? So, so I listed a menu we are not yet there in terms of having tested everything, but we do want to explore and keep learning and keep engaged with the various technologies as and when they are coming up. On the state perspectives, I think our learnings have been what has kind of worked, and Dr. Gaurav will be most likely agreeing to that. We started with a co-designing phase, co-creation work, whatever you call it here, where we got under the government leadership, all the stakeholders together to co-design a project, so to speak, and it was a project to demonstrate at a reasonable scale how you can implement a resource stratified care pathway. We did it in UP and in Jharkhand. So there was NHM representation, there was a directorate representation, there was an academia representation, and there was a technical experts representation. The likes of Dr. Gaurav, he of course played a leadership role there, but also he brought his own team there, who could then talk and engage with the NHM, policy maker of what is needed and have that conversation going. Together design a program, then when it gets implemented, it has sort of ownership by everybody. So that was one important thing that worked in that space. Now, the other thing, we also found that state governments want to invest. It's a political priority. They don't know necessarily the how of it, and they need facilitation and technical assistance. And they don't need like always, the high end only kind of thing. Of course, we need a lot of medical oncologists, surgical oncologists, etc. But they need also the technical facilitators, bringing people together, identifying what are the available, easy to use resources, those kind of very basic things, which needs both capacity and competency. So that is a huge lever, and a driver to make these things work. Measurement. Currently, there is no way to measure, progress on cancers. Only, access indicators are written. So we have to work with the government, and they seem to be ready. But again, the capacity and competency limitations are there. And finally, I think one thing that we learned that if you want to implement this kind of a program at a scale, you need to integrate services within the existing health system and primary health care. So that is a very key element that we all need to, you can't necessarily, I'll give an example, and this may be a bit provocative and maybe intentionally so. The National Cancer Control Program, is a vertical, written in a way which looks like looks like a vertical program, positioned as a vertical program. But for that to successfully get implemented, it needs to be integrated at state and district and the frontline healthcare worker level with the existing health system. So while the owner of the cancer control program at the state level is one person sitting differently separately from the NHM, the money is going to come from NHM, and even similarly, the frontline worker is the same, the ANM and ASHA, who has majority of control by the NHM now, by virtue of many levers that they have. So integration at different levels of health system, from the policy to programmatic planning, to resource allocation, and finally at the service delivery level and review level is key to getting this, thing executed in a self-sustainable manner. Over.
Absolutely. Thank you, Dr. Somesh, and thank you for bearing with the comprehensive question that I'd asked. But this, we couldn't have, close our today's session without asking that question and getting that response from you. And while we certainly have a huge paucity of time here, but if I give 1 minute to each of you, if you could just summarize, and any concluding remarks from all of you, I'll start from you, Dr. Gaurav. Just quick, if you could just give some closing remarks from your side.
Well, I guess decentralization is the need of the hour. This is a fact which needs to be conveyed far and wide. Decentralization, not just in any one facet of cancer care or breast cancer care, but in for the entire spectrum of it, as I've been saying again and again. The efforts for awareness creation and encouraging early detection have to go right into the interiors of the hinterland and not just be restricted to some major cities. Then similarly, resource stratified care depending on the both dependent on the stage and biology of the disease, as well as the expectations of the patient have to be made aware in all tier 2, tier 3 cities for sure, as also in the smaller towns. And because it's impossible to create islands of excellences or number of centers of high quality in so many places. So there has to be a hub and spoke kind of approach to such things which need care at a larger center to be made available for a large enough population there, and the rest of the things which can be administered, or the kind of care which can be administered even at a peripheral level, must also be taken care of. So that's my summary remark for today's session. And then finally, thank you very much for bringing up this issue for discussion. Discussion leads to some solutions. Who knows? There may be some action at the end of this whole discussion. And I'm certainly hopeful that every passing year we are improving by a small percentage point in terms of the quality of care that we deliver to our patients pan-India. And at some stage, we would pass that critical level where a majority of breast cancer patients are treated well.
Absolutely. Thank you, Dr. Gaurav. And actually, at IHW, the intention is not to, stop when it comes to cancer and breast cancer with certain talks, but also to sort of convert it into some kind of, sustainable and quality action. So yes, it's great to see that kind of commitment from you also. Moving on, Dr. Priyanjali, some closing remarks from you.
I think we all here have gathered today and discussing about decentralization itself is a really positive direction. I would like to close it by, first of all, thanking you to bring this panel up and having me. And secondly, decentralization will happen when, each player at every level has perfected their solution and plugged it all together as a team in the existing healthcare, pyramid. That's when the successful patient journey will happen. So right from unawareness about what is breast cancer to, having a successful breast cancer treatment for anyone who encounters the disease. We have talked about multiple enablers today. We have talked about multiple solutions today. All of it translating into a linear system is the way forward. And I think it's not a tough task to do. It's just the right number of people, right amount of quality of solution together and integrating it to the healthcare system. So that's
absolutely it. Thank you so much, Dr. Somesh. I know I've asked you many questions, but just last some concluding remarks from you.
Yeah, sure. I would just say, we need collaboration, multi-stakeholder collaboration, and a total market approach, looking at all the parts of the health system, which is whether it's public, private, and bring all the existing resources and innovation enterprise together if we have to solve this in a very definitive manner.
Thank you, Dr. Somesh. That was very crisp, yet strong enough to hit the center of the eye. So thank you so much for that. Mr. Uttar, last but not the least, some closing remarks from you.
Thanks, Dr. Nalini, other panelists for a great discussion on the topic today. So I'll just make one single statement on closure. Decentralized and integrated breast cancer care supported by data and digital can go a long way and improving equity for cancer care in India.
Thank you, Dr. Rudra. And with this, we come to the close of our today's session. And I cannot thank all of your participation enough, because while IHW is consistently dedicated to bring in more, work in the space of cancer and specifically breast cancer, your participation in today's panel actually, is a big motivation, first of all, to us. And I think when we are talking about decentralizing the breast cancer care, we are also, I think, by virtue of this conversation today, we decentralize the conversation, a conversation which is not only concentrated in certain pockets. Our idea is to decentralize not only the actions, but also conversation. And this was, this is the beginning of it from us. And I look forward to, prolonged and longer support from all of you on this. Thank you so much for joining us.
Thank you, Nalini.